Hello everyone, in this video we are going to discuss a case presentation of respiratory system. Myself Dr. UMENDRA Kumar, consultant pediatrician. So for the simplicity of the case, I have deliberately deleted certain points and the identification of the patient do not match with real scenario. So there is no such identification of patient in this case. So enjoy this presentation. So, Sanu Munda, a 7 months old male child uh, of Mr. Tehra Munda and Mrs. Sarita Devi, hailing from Dhanbad, a product of non-consanguineous marriage, admitted on 10th April 2026 and was examined on 11th April 2026. Informant being father who is reliable, presented with chief complaints of cough for 25 days, fever for 25 days, and breathing difficulty from last 10 days. History of presenting illness. Cough was insidious in onset, non-productive, more during daytime with no postural variation. Fever from last 25 days of high grade, continuous in nature, not associated with chills and rigor, and not associated with vomiting. Fever relieved temporarily on with medication. He also complained of breathing difficulty, progressive in nature, with increased respiratory rate from last 10 days. Breathing difficulty was insidious in onset and progressive, which is more during daytime. There is no known aggravating factors for breathing difficulty, but baby became irritable with disturbed sleep pattern. There is history of feeding difficulty present from last 10 days. Coming to negative history, there is no history of trauma, no history of foreign body aspiration, no history of cyanosis, no history of henna-sarca, no history of rash with fever, no history of painful micturition, no history of altered sensorium and convulsions. Past history and treatment history, no significant past medical or surgical history was elicited. And treatment history, he was locally treated with oral drugs with temporary relief for 1 to 2 days, but no document was available. On admission in this hospital, he was given IV antibiotics, IV fluids, antipyretics, and intercostal chest tube drain was applied 1 day back. Coming to birth history, mother received 3 antenatal checkups visit and she also received 2 tetanus toxoid, iron and folic acid and calcium tablet supplementation. He, full-term normal vaginal delivery institutional. Birth weight was 3 kg. Baby cried immediately after birth and perinatal period was uneventful. Coming to developmental and immunization history, all milestones were appropriate for age and immunized as per National Immunization Schedule. BCG scar was present on left upper arm. Dietary and allergic history. Baby was exclusively breastfed for 6 months on complementary feeding now and no known allergic history was present. Family history. There are 3 siblings and he is the third child of his father and no similar illness in other siblings. There is no history of tuberculosis, diabetes mellitus, hypertension, thyroid disorder in the family. Socioeconomic history. 5-membered family lived in a kacha house. Father is the head of the family and sole earner. Total monthly income is rupees 4,000 per month. Living conditions: resides in kacha house, 4 rooms, poorly lighted and ill ventilated. Hygiene and sanitation: hand pump for drinking water and practices open defecation. According to modified Kupuswamy scale, he is classified as upper lower class. In general physical examination, on appearance, the child is alert, conscious, and has an average build with moderate nutrition, and he is sitting comfortably in the mother's lap. On clinical observation, chest tube insertion on right side of the chest with purulent collection in the back. IV cannula was present in the dorsum of the right foot. Vitals recording, vital signs, temperature 99.6 degree Fahrenheit taken in the right axilla. Pulse rate was 122 per minute, regular in rhythm, normal in character, with no radio-radial or radiofemoral delay. Respiratory rate was 56 per minute, abdominothoracic in nature, with regular rhythm. Blood pressure was recorded to be 94 by 60 millimeter of mercury, taken in right upper limb in lying down position. Oxygen saturation was 93% at room air. Other findings: JVP was not raised, pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema are all absent. Coming to anthropometric measurements, weight was 6.25 kg as per expected to be 6.7 to 10.2 kg, which is less than -2 standard deviation. Length of the baby is 68 centimeter against the expected 65.1 to 73.2 centimeter, which is between plus 1 SD to 2 standard deviation. Head circumference was 43 centimeter. Upper segment to lower segment ratio is 39 is to 29 centimeter, which comes out to be 1:1.3. Body mass index is 13.8 kg per meter square against the expected 14.8 to 20.5 kg per meter square, which is less than -2 standard deviation, and the child is underweight. Coming to head to toe examination, head and face, there is no dysmorphic features and facial symmetry was there. Nose, there is erythematous swelling over the left side of the nose, which is noticed. Eyes, ears, and throats are within normal limit. Oral cavity, there is no oral dentition yet. Abdomen, presence of an umbilical hernia, no superficial scar marks. Genitalia, external genitalia are within normal limits. On examination of back, no visible pulsation, no kyphosis, no scoliosis. Coming to examination of the respiratory system, coming to systemic examination and in that of respiratory system, on inspection, upper respiratory tract, that is ear, nose and throat, are within normal limit. Respiratory rate is 56 per minute. Movements, decreased movement with respiration on the right side of the chest is noticed. Intercostal space, fullness noted in the intercostal space on the right side. And clinical status, no nasal flaring or retraction is visible. Bandage and chest tube in situ on the right side of the chest is observed. Coming to palpation of respiratory system, temperature is normal, tenderness present. Trachea is shifted to the left side, decreased movement of right side of chest with respiration. Tactile vocal fremitus is decreased on right side of chest, which was performed while the child was crying, and normal palpation on left side of chest. So since this is a very young infant of 7 months, so vocal fremitus was done while the child was crying. In elderly children who can follow your commands, the tactile vocal fremitus can be asked after saying 1, 2, 3 or any word. Coming to percussion of chest, dullness on whole of the right side of chest is elicited, and normal resonant note on left side of chest is elicited. On auscultation, decreased vesicular breath sound in all area of right side of chest, and normal vesicular breath sound on left side in front, lateral and back of chest. Vocal resonance diminished on right side of chest and normal vocal resonance on left side of chest. There is no adventitious sound on left side of chest was audible. Coming to examination of the cardiovascular system, normal precordium with no visible pulsation, JVP not raised, apex beat felt in fifth intercostal space lateral to mid clavicular line. First and second heart sounds are audible and there is no murmur audible in this case. Coming to examination of the abdomen, all quadrants move equally with respiration. There is no organomegaly. umbilical hernia of about 3 centimeter present, and bowel sounds was audible. Examination of central nervous system is within normal limits. So coming to case summary, in this case, Master Sanu Munda, a 7-month-old male child, presented with insidious onset non-productive cough for 25 days, sudden onset of high-grade fever which is continuous in nature, not associated with chills and rigor, and not associated with vomiting for 25 days. He also complained of insidious onset of shortness of breath, progressive in nature, with preference to lie in a right lateral position. And on examination, with a heart rate of 122 per minute, respiratory rate of 56 per minute, oxygen saturation 93% at room air, with other vital parameters within normal limit. On general examination, pallor is present, icterus, cyanosis, clubbing, lymphadenopathy, and edema are absent. On examination of respiratory system, upper respiratory tract within normal limit, intercostal chest tube drain with underwater seal in situ on right side of chest with swing of air column, diminished movement on right side of chest with respiration, and normal movement on left side of chest with respiration. Fullness of intercostal space on right side of chest. Trachea and mediastinum is shifted to left side. Tactile vocal primitus decreased on right side of chest. On percussion, dullness on right side of chest is elicited. Decreased vesicular breath sound on right side of chest. And examination of other system is within normal limit. So my provisional diagnosis is this is a case of right-sided pleural effusion, may be due to parapneumonic effusion of pyogenic in origin. So friends, this is how you can present a case of respiratory system, and you can add or subtract as per the age of the baby. As in this case, this is 7-month-old child, so I have not mentioned regarding the detailed feeding history, or whatever may be the changes in other cases, you can add or subtract. So in next video we will discuss about the what are the different questions that will be asked in regarding these cases, or in a case of pleural effusion or empyema. Till then, enjoy this video and share with all your friends who need to take a good history of respiratory system. Thanks